and welcome to Rad Chat, the award-winning therapeutic radiographer-led oncology podcast. My name's Jo McNamara and I'm joined by fellow hosts Nev and Joel Canderson.
Hello everyone.
So we're really lucky to introduce today Simon. Simon, do you want to introduce yourself and explain a little bit about your role?
Yeah, sure. So I'm Simon Goldsworthy, consultant therapeutic radiographer specialising in breast cancer in Taunton, Somerset. And I am here today presenting my PhD work, the Comfort Study. So that was this morning. And this afternoon was a workshop that I co-hosted, which was about compassion to our patients, to each other, the organisation, and self-care as well. So, yeah.
You've been busy.
Been busy today.
What got you into radiography? Let's take you all the way back.
Wow, Naaman, that's an interesting one. So, the beginnings for me were going to an open day in Ealing, London, and looking at the variety of professions. And this is after I'd been working in healthcare for a while. So I'd been a care assistant, and I thought to myself, I want to do something in healthcare. I like being with people. Looked at the different NHS professions, nursing, allied health, and then found therapeutic radiography. And two things stuck out really at the time. What they sold to me was the patient care, which I just lapped. I thought that's great.
Yeah.
There was the technical side of radiotherapy as well. And then interestingly, and this must have been just its conception, is the the career structure, which was practitioner, senior practitioner, advanced practitioner, what it was at the time, and then consultant. So that's what hooked me in. Initially I thought, actually this is a profession not only looks really interesting from the patient and the people perspective, the technical, but actually there's a career in radiotherapy. It's interesting really, and I say that because when I qualified in 2005, I was out there on the front line at the Royal Sussex County in Brighton, and realised that actually this was so fresh, it hadn't actually been implemented at all, and I slowly started to see things roll out very, very slowly. But today we're obviously seeing these roles more and more. I'm a consultant radiographer now myself, which I didn't foresee either. There's been sessions today on advanced practice, consultant practice. I've seen some of them, but I had to leave for the session that I was doing this morning. So things have just gone, have come on leaps and bounds when it comes to advanced practice in all of the AHP professions, specifically radiotherapy.
So Simon, can you tell us a little bit about your PhD? What were your findings?
What were my findings? There were three main studies in my PhD. The first was a systematic literature review, which was quantitative. So that found that there were lots of potential comforting interventions that could be used in radiotherapy, that were used for other clinical procedures that was similar to radiotherapy, and that it was about patients sustaining position for an extended period of time, so above 10 minutes. So that was the first thing. There were lots of potential comfort interventions, characteristics that could be then used as, like, if you like, the ingredients to make something specific for radiotherapy. Also, within that same study, I looked at clinical significance. So you've probably all heard about statistical significance, p-values and such like, looking at the difference, which sometimes you're looking at two figures for something. Statistical significance is just telling you there's a difference.
Yeah. So
clinical significance takes it that step further to say, hang on a minute, what does that actually mean for the patient? And so there was only a few interventions out of, I think it was 5 interventions that were clinically significant, which the basis for determining clinical significance were an effect size above 0.4, good inter-rater agreement, and an acceptable risk of bias. So it was quite a criteria. The next phase of the studies were interviews, so that's qualitative. So that was to draw out the views and experiences of patients and therapeutic radiographers from around the UK. So there's 25 patients, 25 radiographers, to look at their experiences, views of comfort, and how it can be best managed. So that took a deep dive and explored, provided a greater understanding of patients' experiences of comfort during the procedure of radiotherapy. But then the sub-study to that was to look at how it was best managed. And so from that, there were lots of, there was 3 themes overall, but there were lots of sub-themes that indicated potential comfort solutions that could be used. Right. That together, so the comfort solutions from the sub-themes of the qualitative work, along with the comfort intervention categories from the systematic review, were triangulated, synthesised into a list of potential comfort intervention components, which then which were then prioritised in a consensus study, a nominal group technique study, which, in a nutshell, we ended up with 11 interventions which were included with caution, because they were either a reasonable priority, but not necessarily with good inter-rater agreement. Right. So 11 comfort intervention components that are recommended for development of a comfort intervention package. So that's it in a nutshell. And I make it sound very, very brief.
A lot of years worth of work into essentially a 3-minute pitch.
Exactly. I make it sound very, very brief and in a snapshot, which is what it is in a nutshell. But there was lots of painstaking hours with all of it, really. Every phase of the studies, even the data, crunching the data, going through the systematic review, 5,200 articles were screened. Then the data, even of 46 randomised controlled trials, the data from 46 studies was extracted. Then there was further analysis on 26 of them for the clinical significance. So not all of them were evaluated for that because the data wasn't available. Then the interviews, my goodness.
The also time. Pandemic as well.
Yes, so that affected the consensus study, which was all online. And that has its benefits, and it also has its negatives potentially. Yeah. So you don't have that human interaction. But then participants or panel members, they're called actual participants, are then, maybe they could feel freer to answer and complete their prioritisation, make any comments. So there are flip sides to it. But
so how has what you found from your PhD now been implemented in your department?
It hasn't just yet, because there's further work to do, and that's why coming here to put it out there is a way of saying, look, this is what's been done so far. Yeah. It's not just for me to use what I've done so far, it's for other people to say, hey, look, let's continue this focus on comfort. We've got a solid foundation here, we've got some evidence, let's proceed. There's 11 comfort interventions there that look suitable to radiotherapy. Hey, we don't need to use all of them, but these few look good. Yeah. So there's more work to be done to test in radiotherapy.
Have you had any engagement from industry? I was thinking if there's 11 interventions, would they potentially help in the future to make it more widely available?
It's possible if most of them are things that you would do in-house. I say in-house within you want to trial it, I would say, field test, trial it, but things like stretching and exercise before radiotherapy or coaching. So these are some of the interventions. Right. It could be something to do with psychological therapies. It could be to do with using a different type of immobilisation, so something softer, cushioned. It sounds obvious, but assessment of compliance and things like that. So some of these things, but there are others where there could actually. I tell you what, there could be. Maybe I'm giving away something here, but this is for the benefit of patients. So for me, it doesn't matter. You could have some app, a patient app, which could give them a choice of a toolkit of these intervention components. And then within the app, so if it's stretching or exercises, you've got the stretches and exercises that will help prior to radiotherapy to relax certain muscle groups, to ease the gas, depending on what part of the body it is. Yeah. Ease gas if they're pelvic, if they're breast and they breast cancer and they have breast cancer radiotherapy, to get the arms mobile to achieve bilateral arm abduction. So there could be in that sense, there could be in that sense.
Or Simon, there could be a podcast that has lots of social media engagement which has exercises for patients, like we do on Rad Chat.
There you go, then. There you go. But that was just one example, I suppose. But there's lots in there.
Yeah.
There could be meditative, all sorts of different interventions. So
it's really interesting, and I think I'm really passionate about prehabilitation.
Yes.
And it
so there's a
fits
crossover
beautifully
in
that, doesn't it? In that sphere.
So there's a crossover with that, actually, and of course I also teach for the Estro School, and so there's we talk about prehab, we talk about the comfort related stuff, we talk about the technical, we include it all, and so there certainly is for prehab. There's a lot of crossover.
Yeah.
So
Before you go, Simon, thinking back to obviously we're at a conference, there's lots of students or junior people. What advice would you give them about getting into research?
Goodness, well, I don't think any pathway is that kind of clear, but I think what you should do is use your passion. If you really find something that it annoys you in practice, use that as your...
That's everyone now starting to do research, surely, Simon.
That's a good thing.
Use that as your initial driver, whatever that might be, because that's what I did in the early days. I think everybody was involved in skincare and creating new guidelines in whatever hospital they were in, radiotherapy department. And so it annoyed me, for example, that aloe vera was being used, but not just that patients, it was ethical, I suppose, patients were being advised to buy certain aloe vera deodorants costing £20-30. This is some years ago, and so that annoyed me so much that I was thinking, hang on, but the evidence is saying that aloe vera doesn't suit everybody, and for some it can cause dry desquamation. So we need to be careful on what we're suggesting here, and so with colleagues we produced the evidence-based skincare guidelines in the hospital I was working in, and so that's what I would say is whatever annoys you in practice, use that annoyance to drive the evidence change. And I think you can start small. I mean, that if you like, is a small way to start, is evidence-basing an area of practice, whatever it might be. It could even be to do with, let's think on the front line of radiotherapy treatment. It could be to do with where you set a patient up from. Is it from the top of the couch? Is it from the tattoos? What's the evidence for doing that? You could collect your own data, evaluate it, and then prove to your team that it's better to, for example, I'm not saying this is true, start from tattoos, as an initial setup. So it could be anything. I think starting small, finding something that annoys you, starting small, gathering a team. If you're junior, find an ally, a senior that's going to work with you.
That's what you did for me. 2018?
Yes.
So 2018 UKIO. That's how I got to come here then.
Simon, I'm concerned though, because you're very well published. Does that mean that a lot in radiotherapy has really annoyed you over the years?
Yeah.
Yes. Well, perfect.
I think there's got to be some sort of driver. I think annoyed is a strong word, isn't it? But there's got to be something that drives that passion.
Yeah.
Say, I want to do research in this area. I mean, comfort. I mean, aiming to improve comfort for patients undergoing radiotherapy. My goodness, it's too many years I've been doing that, and but I'm seeing lots of people. There's lots more interest in trying to improve comfort in radiotherapy, and yeah.
So not annoyance, passion.
Both. Yes. Both, one or the other.
Thank
one or
you.
the other. A bit of both. Thank you.
Thank you so much for joining us.
Thank you.